Hello, everyone. Welcome to the March edition of the Pain Research Working Group. Happy to have you here. I'm going to go ahead and introduce our speakers for today. The title of our presentation for today is Person-Centered Language in Scientific Articles Related to Opioid Use Disorder. Our presenters are Dr. Micah Hartwell, the Clinical Assistant Professor of Psychiatry and Behavioral Sciences at Oklahoma State University. Dr. Hartwell's research focuses on systemic public health topics, including food security and addiction. He obtained his PhD from Oklahoma State University's Educational Psychology REMS program with emphasis in applied statistics. Dr. Hartwell received additional education and training from the University of Florida's College of Public Health, Johns Hopkins Bloomberg School of Public Health, and the University of Oklahoma Hudson College of Public Health. Partnered with Feeding American and Cornell, the National Center for Wellness and Recovery, and the Laureate Institute for Brain Research, conduct and publish studies on drug and alcohol use and effects, prenatal exposures, and related stigma. Our second speaker is Brett Traxler, who's a medical student at Oklahoma State University College of Osteopathic Medicine. Brett Traxler is a fourth-year medical student. He will be matching into an anesthesiology residency program this month to begin training to become an anesthesiologist. He received his bachelor's degree at the University of Oklahoma in Health and Exercise Sciences. As a student researcher in the Office of Medical Student Research at OSU, Mr. Traxler's focus is on meta-analysis and use of person-centered language in scientific journals to reduce stigma. Thank you for joining us today. I'm going to go ahead and turn things over to you, and I'm looking forward to hearing the presentation.
Thank you guys for having us today. Can everyone see my screen? All right.
Good.
So, like she said, our focus today is going to be about person-centered language as it relates to scientific articles in opioid use disorder. We were asked to give this talk as we know that as addiction researchers like yourself, it's important to use person-centered language as opposed to stigmatizing language. And we know that this has direct effects on clinical outcomes for patients. So we have nothing to disclose, Dr. Hartwell or myself. So first off, a little bit about where we're coming from. We're in Tulsa, Oklahoma at Oklahoma State University. And as you may know, a couple years ago in 2019, the state of Oklahoma had a historic settlement with Purdue Pharma. And we were able to establish a nearly $200 million endowment at the Oklahoma State University National Center for Wellness and Recovery. And this will go toward treating patients in the ongoing addiction epidemic, not only in the state of Oklahoma, but nationwide. The National Center for Wellness and Recovery was opened a year prior to the settlement in 2018. And the mission is to inspire hope and to develop innovative science-driven treatment interventions to improve the lives of those afflicted by pain and substance use disorders. And as this is a VA group, thought we'd also mention too that in 2024, Oklahoma State and the VA system is partnering together to open a new hospital in downtown Tulsa, just across the street from the current University Medical Center. And so open 2024, and this hospital will be closer to 68% of the veterans living in eastern Oklahoma, as opposed to the current one now that's about an hour and a half away from the Tulsa metro area. So I don't need to go much into opioid use disorder, opioid epidemic as definitions or anything like that, because you all know much more than I know about it. But we know that in the last year, especially during the height of the COVID-19 pandemic, drug overdose deaths in the United States were up 28.5% from the year prior. But specifically, the opioid epidemic in Oklahoma, in 2018, there were nearly 80 opioid prescriptions for every 100 people living in Oklahoma, which is much higher than the national average of 51.4%, or 51.4 prescriptions. And we know that opioid addiction and substance use disorders as a whole affect rural communities more, and Oklahoma certainly has an abundance of rural communities. But nearly 80 for every 100 people is better than in 2006 in Oklahoma, when Oklahomans were prescribed 109 prescriptions for every 100 people in 2006. And our opioid overdose death rate was less than the national average in the past year, 16%. 16% increase, I'm sorry. So opioid use disorder, as a definition, as you know, we know it affects over 2 million Americans annually, and there are over 120,000 deaths worldwide attributed to the use of opioids. We're going to talk about stigma, Dr. Hartwell.
So stigma is a multi-level construct of labeling, creates a power imbalance between a majority group and minority group, resulting in a devaluation of the latter, subsequent social inequities, and negative physical and mental health impacts. Stigma at the systemic level signifies a majority social acceptance, reinforcing the diminished value and autonomy within the targeted population, which can lead to policies supporting this and leading to systemic bias and worse health outcomes. So this translates into unfair and unattainable expectations and roles, leading to diminished opportunities, which plays a role in disparities and equities. And from there, it leads to internalized stigma and self-stigma, which is when individuals have their own narrative, which they often blame themselves, leading to reduced self-esteem, autonomy, and ultimately a lower quality of life. This cycle is repetitive, and it very much impacts stigma in this repetitive cycle. So this diagram just really shows emphasizes the flow of that external prejudice all the way around to internalized shame through multiple mechanisms.
And so to help fight that stigma for patients, not only with opioid use disorder, but all substance use disorders and medical diseases as a whole, is person-centered language, which isn't a new or novel concept today, but person-centered language are all referred to as PCL. The definition is it's a style of communication that incorporates an individual's preference and identity when referring to a disease state. And this is straight from the American Medical Association guidelines. And so, for example, patients will likely prefer to be referred to as an individual with opioid use disorder rather than labeling that person as a trait of their addiction, such as an opioid addict or opioid user or abuser. And we know that the employment of PCL, it promotes a culture of inclusion and reduces the stigmatization of individuals who are often minimized and cast aside as their labels. And so we decided to focus our research on this because these are straight in the American Medical Association guidelines that we're supposed to use in scientific literature.
So just a brief history. In the 1970s, sociology and psychologists started to make a major advocacy shift for removing labels from legal documents and within medical literature. And that really took ground in the 80s and led to the APA establishing PCL guidelines in the 1990s, the early 1990s. I believe it was 94, when they established person-centered language, actually person-first language within the APA guidelines. In 2001, as a component of patient-centered care, the IOM adopted and made a move towards person-centered language, and within their IOM guidelines, said that language should follow the patient-centered care that's respective and responsive to individual patient preferences, needs, and values that ensure patient values guide clinical decisions. So after the IOM adopted it, it was moved to the ICMJE, which identified respectful language as a component of the ICMJE requirements, which was later adopted in 2008 by the AMA guidelines. So the 10th edition of the AMA Manual of Style adopted that PCL ratification specifically, and had three major components. And the first one is to avoid labeling, thus equating people with their disabilities or diseases, and instead put the person first, which is where person first style really became a hot topic. It was it was later adjusted slightly to allow for person first style or identity first style, depending on the group that was being identified. A couple of exceptions of groups that prefer identity first language are the blind and deaf community, as it's an innate characteristic to their being, as opposed to a treatable medical condition in which the individual should be placed in front of the condition. Second bullet point in the AMA guidelines says avoid describing persons as victims or other emotional terms, which in our papers we talked about as emotive language that suggests helplessness, such as afflicted with, suffering from, or stricken with. And then the third one is avoid euphemistic descriptions such as physically challenged or special. And then in 2018, kind of unrelated, but 2018, they went further. The AMA guidelines adopted a proposal or resolution to adopt specific PCL guidelines in reference to obesity. And then flow of information. So as a public health researcher, I always try to, and I'm sure everybody here knows, you always try to stem things at the most upstream factor. And when I was developing this methodology with a couple of students that I was working with to examine person-centered language within medical research, we really, examined how the flow of information divulges from what we identify in medical literature and medical research and how it flows downstream. So as written, and one of the key components to this is medical research is the unidirectional flow of information. There's no real feedback loop beyond reviewers and possible editors. So as research manuscripts are a unidirectional flow of information, researchers, especially from the medical community, must be intentional with their writing and discussions of individuals with substance use disorders. Medical research and the descriptions of the people and populations described therein are disseminated through faculty and textbooks through future generations of medical students passed on and other healthcare professionals. And that's really providing a lexicon for which medical terminology is used. Further, when articles are published, the language in the manuscripts is often translated into headlines picked up by the media. And both medical education and media outlets are ways that provide direct influence to healthcare professionals and into the general public. All of these form public opinion in which a repetitive cycle of stigma may be reinforced. And on this graph, the only portion of this that's bidirectional communication is really between healthcare and patients. So that flow of information from the most upstream factor really has that long-term downstream effect.
And so I know for myself personally, during my third year when we were doing this research on the wards in the hospital, I would see a patient that drank or smoked or had opioid misuse or any substance misuse. And before this paper, I would refer to them as, well, they're a drinker, they're a smoker, they're an alcoholic, they're addicted. And it really it caused negative perceptions like, why are they doing this to themselves? This is their fault. They're here because of these decisions they've made. Instead of realizing there's a multitude of reasons why individuals choose to pursue those substances, but it really takes away from the identity first and giving the patient the power and giving them the best help that they need. And so in research, how does this affect clinical care? They did a survey of medical residents, and they were looking at charts of patients with sickle cell disease. And in half the charts, when referring to patients with sickle cell disease, they use stigmatizing language, such as a sickler. And then in the other half, they used neutral language. And it was found that the medical residents and the sickle cell patients with stigmatizing language, they were less likely to be aggressively treated for their pain. And then the attitudes of the residents toward those patients were more negative than those when neutral language was used. And then the public and patients with substance use disorders, everyone watches TV or checks Twitter or gets news in some form or fashion. And so a study from 2008 to 2018 with nearly 6,400 articles related to the opioid epidemic, half of those articles or stories use stigmatizing language. And so not only does this affect researchers and physicians when talking to patients, but the public as a whole when their neighbor may have opioid use disorder, they're more likely to adopt this stigmatizing language and these negative attitudes when person-centered language is not used. And so now for our study, person-centered language in OUD. Our aim was to determine the adherence to PCL in OUD-related publications according to the AMA guidelines that Dr. Hartwell mentioned. And so we thought that this was important because, like we said, it's important for authors to be cognizant of the language they choose, because these OUD-related publications for the people that fight the patient addiction, such as physicians, psychiatrists, therapists, and addiction researchers. And so the use of stigmatizing language in this setting in patient care, it reinforces the acceptability of stigmatizing language in these labels in professional practice. So for our methods, we searched opioid use disorder articles in a 4-year time span ending in December 2020, and we searched for the keywords that are on the screen. And our initial search, we got over or nearly 3,000 articles from over medical journals. We excluded all journals that had less than 20 opioid use disorder related articles in those journals, as we thought that those that are helping treat opioid use disorder are going to read journals with more opioid use disorder related papers. We also excluded letters to the editor and editorials and tried to include only objective scientific research, such as original research articles, case reports, brief reports, and research letters. And we performed this in a double-blinded and masked fashion until 300 articles were screened and met all our inclusion criteria. And then those 300 articles were searched for the bolded terms, as you can see on the screen, such as addict, user, abuse, abuser, and then the emotional language, such as suffer, afflicted, or problem. And then after two of us searched these 300 articles, we met and reconciled any discrepancies in our data. For the results, 70% of the 300 articles were original research articles, with 60% of those being observational as opposed to clinical trials. Nearly half were grant funded, and 50% of the OUD related articles focused on medication assisted treatment. So out of our 300, only 20% were fully adherent to the American Guideline on Person Language, which used 0 stigmatizing terms in their paper, which means 80% used at least 1 stigmatizing term in their research article. The most common label that was used was user, and it was used in nearly 50% of the articles. Emotional language is used in half of the articles, with abuse and problem being the most common. And emotional language such as abuse, it implies that the individual is deliberately or willfully engaging in this act of misusing opioids, which then gives the perception to others that it's a moral failure of the patient or individual rather than the actual disease process of addiction and how it affects the individual. And then here's a breakdown of all the terms that were used and their frequency. And suffers from was another prominent one at nearly 15%. So identity first label first. Like I've mentioned, we know that we need to give power to the patient and not refer to them as their labels because it hurts providers' perception of the patient as well. And a study of just the general public, they asked about attitudes of people that were, quote, mentally ill. And those people had negative attitudes towards those that were, quote, mentally ill. But then the same people surveyed, they said, well, how are your attitudes about individuals with mental illness? And their attitudes were vastly different toward those people, just because of a simple identity first label first, and giving the power to the patient or the person. And then in a survey of opioid use disorder patients that were currently in treatment, 70% of those patients, they referred to themselves as a label, as an addict, instead of anything else they could describe themselves as. They saw themselves as an addict. And so because these individuals see themselves as an addict, multiple scientific studies show that patients are less likely to seek treatment when stigmatizing language is used. And in opioid use disorder specifically, only 20% of individuals sought treatment help in 2016. And so in our conclusion of our paper, we suggested that medical journals should refuse to publish papers with this harmful stigmatizing language. We made a nice chart of things to use instead of our labels that we search for or the emotional language that we search for in our article. And the AMA guidelines, the person-centered language that was set forth in over a decade ago, it just needs to be more adhered to. And we know that scientific writing should be objective and that research should be culturally informed. And it's easy to refer to someone as an addict. It's one word, it's simple, and you get the point. But person-centered language and really what benefits the patient most would be to refer to them as a person with substance use disorder. And so this was our paper, the full title of it, and it was published on November 1st of this past year in Drug and Alcohol Dependence. Any questions?
I was looking at a couple of questions in the comments. For the 20 article exclusion, did you make any exception for high impact medical journals? So no, we didn't look at we looked at journals who published at least 20 OUD related articles over that 4-year time period, because we felt the rationale behind it was that they're more likely to be familiar with and be experts in that field, or at least their editor to be more comfortable editing those journals. So we wanted to basically when we look to critique a particular topic, we want to pick out the highest producing journals or articles from those journals, because we feel like those would be the most we felt they would be the most cleanest. And if we're going to pick apart somebody's language, we want to pick apart the experts. As I'm a critical theorist, so I like to pick apart from the inside. So I always keep things that my realm is doing. The second, it'd be interesting by impact. So I just put that in the chat. We looked at H-index rather than impact factor. It's a little bit easier to gauge H-index. We used the SJR system or the SJR website to pick up the H-index, and we found that it was very non-statistically significant. It was P equals 0.9. Clinically, how do you address when patients themselves use stigmatizing language? This is not meant to be like making fun, but like I always use first names. So when I'm talking to either clients or researchers or research participants, typically I use first names. If they're referring to being an addict or call themselves an addict, I always redirect to talk about, their addictions or what they see as the problems that they're trying to overcome. Let's see, what else? Is there any other? Nope, those are the three. And so I've worked with a couple of different groups to publish papers in PCL. The original paper was over alcohol use disorder. This is our second. We've also looked at drug-seeking behavior and just looked at a stigmatizing terminology paper of AUD clinical trials, looking at stigmatizing terms for outcomes and processes. So we published a little bit in this field. Anybody else have any questions?
So I love the presentation. I think one of the things that I come back to is we talk a lot about the use of person-centered language and reducing stigma in kind of our clinical circles and our research. But I'm wondering if you have any thoughts on what's the best way to integrate this into an education setting? Because I know in my own training, I didn't really have, we talked about, stigma, particularly mental health stigma. We didn't talk a lot about substance use stigma. And I think, in this era where we're increasing our awareness of how we're interacting with patients, do you have any recommendations or thoughts on what's the best way to sort of integrate this into training across disciplines, and at what stage should it occur?
Honestly, this is my this is one of my lines of publications that has kind of taken off. I've worked with people across the U.S. On it, and everybody has that same question: where do you integrate it? How do you integrate it? And I've started with the students that I work with. I will bring groups of students in, and it's been one of those organic things where several students, including Brett, will start noticing faculty members using stigmatizing language within their lectures, within their medical lectures. And first, that generates a new topic to do a paper on. But it's been a push to get first and second years involved and incorporate that into the medical education system. So I'm working with the dean of one of our campuses to incorporate person-centered language training at year one, so people are aware and identify. And I think the only I don't even call it pushback, but the things that have been hardest are some of the older faculty members have just have that ingrained, and it's been trying to change language in slides and change language within some of the talks.
I'm wondering even earlier than that. I mean, as an undergraduate, and I was an undergraduate a long time ago. I mean, this was person-centered language was not even a topic, I think. And this is, I mean, it's not that long ago. It was in 2000, 2004, and I think now I'm interacting with more undergraduates through teaching and things like that, and that there still is this, there isn't a lot of knowledge about person-first language, and words like alcoholic, addict, and things are still really commonly used, particularly among individuals, students that have no exposure to substance use, or individuals who use substances. So beyond maybe family members and things like that. So, I wonder if even, I know there's been a push to rename courses that are like drug abuse and behavior, to rename them sort of like drug use and behavior, or drugs in the brain, or something like that. And so I see that as another way to really get even earlier than grad school training, because then it's just breaking habits that kind of form in earlier education.
Yeah, and I think so. Obviously, I feel like going to the most upstream factor, if we can change what language is used in medical research, hopefully that'll flow into textbooks, and we will just phase this out. I know that's a long-term approach, but I feel like if we can start at the top, hopefully it'll flow down. I know trickle-down economics doesn't necessarily work, but I think we're in a different era.
And DARE certainly didn't have any person-centered language back when I was subjected
No.
to it. So.
Okay, so.
Yeah, so the question I had was more, because I have colleagues who mean well. I mean, even, we're going to be people I may be collaborating with on various different projects, trying to actually decrease stigma, who sometimes still use it, you know what I mean, in some of their, so it's like, how do you do that in a way, kind of, I don't know how, if you have any suggestions on how to address that, because again, in real time, it's like you cringe, and then you're like, oh, okay, how do you kind of, you want to preserve that relationship, but at the same time, you also want to help with educating them.
Are you talking about, I missed the first part of that question. I feel like
when your professional colleagues, you're in a meeting with the colleague, right, talking about a presentation you'll be doing, and then they use that, stigmatizing terminology to refer to the people you're going to be presenting on, for instance, right? How do you kind of, how do you do that in real time? Like, what would be your suggestions?
I usually come up with a question where I can reframe it. Like if they're talking about, if they say something like alcoholics prefer or have disparities. Most of the time I'm in discussions about disparities, and they'll say alcoholics or something. I'll say, well, individuals with alcohol use disorder, or I'll ask them a question and frame it like, what disparities do you see most in clinics among people who have alcohol use disorder? Just kind of to throw another, part out to remind them. A lot of people are I would say most of the colleagues who I interact with, I mean, just because they know I've been doing this for a couple of years now, be like, oh yeah, person-centered language. Funny story, I had a student so all of the students I work with, which I worked with about 146 students over the last 2 years, know about person-centered language, and one of them presented a poster it was OSU Research Day, but they submitted a poster titled a cross-sectional analysis of osteoarthritic Latinas, and I was just like, oh no. Like, and I had like when that came across there, I had a couple of faculty members like, did you approve this? And I was like, no, I didn't. But it's like I usually try to redirect and ask a question where I reframe it as alcohol use disorder or a person with opioid use disorder.
It's super helpful.
So I'm reading the question as about, I'm in like the 12-step program and recovery groups and their terminology. I'm not a huge fan of them reiterating that they're an addict, but some of those 12-step programs have shown to be helpful for a select population that's like for a subgroup who actually are in those groups where that works. And as long as they're using a harm reduction approach, my AED paper specifically says we did not include 12 and 12 or 12-step recovery programs. And if they're using it and it's working, we're all for it, but it shouldn't be used in medical literature unless it's specifically referring to that dialogue. What else? I was wondering. Yeah, so the individual with the substance use disorder, I want them to have autonomy to call themselves whatever they want. If they introduce themselves to you, like in a clinical practice or a research setting, and said, "Hey, I'm Bob, I'm an alcoholic," you say, "Well, Bob, what can I do for you? How can I help you? What do you hope to overcome within this therapy session?" So I am all for providing individuals with autonomy. That's the whole focus of patient-centered care and person-centered language. If you're presenting and you're talking one-on-one, that's bi-directional communication. If they say, "This is what I want to be called," man, call them that. I mean, I would always say, try to reframe that, but especially in the terms of alcohol use disorder, somebody continually referring to themselves as an addict, it may reinforce the fact that there is some negative stigma there and some internalized stigma. And try to, if you're in psychiatry or psychology, you want to try to reframe that mental stigma or that mental narrative. But as long as it's that initial, you're trying to build rapport, follow the person, meet the person where they're at.
Hey, this is Eleanor Lewis, and I'm a sociologist by training also. And one of the things I was wondering was whether if there's been any efforts to work a bit upstream in terms of working with like editors of journals or even the copy editors of journals to bring this issue more to the attention of people who can kind of intervene around language use.
There is some. So the stigmatizing terminology paper was published with the journal editor in her journal is Alcoholism, and I would butcher it it's Alcoholism : something else. But it's Katie Weekowitz, who you may or may not be familiar with. She's been in the addiction research realm for a while. So she's very aware of it. There are a couple of journals that are specific to patient-centered care who are aware of it that have reached out. And we're also working with the test writers for COMLEX to try to review some of their test guide booklets for the use of stigmatizing language. There was a student the other day who was preparing for the USMLE. We haven't made it to the USMLE yet, but took a picture of one of his test questions, and it was like something like, "A homeless alcoholic comes into the clinic and presents with this. What do you do?" And I was just like, "Oh my God!" Like, I don't know. I'm sorry. I'm really informal, so when I get worked up about some of those things, like, wow, that's terrible. That's in a review prep for. That's how indoctrinated some of these stigmatizing terms are within medicine.
Yeah, I mean, I'd imagine that they're kind of deeply embedded in a lot of places where you have to be attuned to even know to look, even though once you look, you start finding them. I suspect the same may be true in kind of in policy documents. I know I work in the Office of Mental Health and Suicide Prevention, and Elizabeth, I think, has dropped off the call, but she got a hold of some contracting document like between VA and TRICARE or something, And there was deeply stigmatizing language about medications for addiction treatment in that contract. So it is, once you become attuned to it, it's amazing how many places you find that it's become embedded.
And then you could start spreading to all the people you work with about, hey, like, this is not right. Let's redo this and start working on that. And just, it's been one of those, here at OSU, it's been one of those grassroots things. And everybody I've come in contact with is now pointing things out, like even within our like faculty handbooks of, hey,
Yeah.
these are not, like, this is not okay. Like, we need to reword all of this. Our DEI handbook has just gotten a huge overhaul. It's been one of those things that has really taken off here, and I'm happy to spread it around and talk about it as much as I possibly can. Because I feel like if we're all in the world of medical research, and should be, just like our point said, you know, it should be medically accurate and clinically precise, completely objective. When we write papers, we want to just, this is what we found.
Dr. Hartwell, this is Alicia Hebe. This was a really interesting presentation. I really appreciated also pointing out kind of the role of researchers and our communications and kind of the role that that plays and kind of that responsibility that we have. And I was just kind of wondering a little bit, I guess, about process maybe, like a bigger picture. So, I mean, we all know language evolves and changes, and we hear about moving towards more person-centered language, and then potentially patient groups maybe having even new evolving language that they prefer. Or you mentioned, I thought, you know, deaf and blind persons who prefer to be referred to in that way because that's a part of their person. And so I wonder, what is the process then for coming to agreement around person-centered language? Are patient groups brought in for their consultation? And how does something like this, I see that like on one of your slides, you mentioned the AMA had adopted, like how does that process work where it becomes more formalized and actually can lead to change?
So a couple of different, like a couple of ways. Usually it's a large advocacy group. So like the the Obesity Society is the one who proposed the formalization and adoption of new like obesity specific guidelines. And so we just did one on person-centered language and child obesity research, looking at very current 2018 and later. And within medical research, like we excluded editorials and commentaries. We found chubby, fat, and large describing children who were overweight, which that's a whole nother thing that gets me worked up. Children are children, and you know, and then anything after that is describing a symptomology. So the other part, another way that came about, the UNAIDS guide to stigmatizing terminology for HIV, for people living with HIV and AIDS, was adopted from an HIV advocacy group in the early 90s. It was formalized a couple of times. The last one that was updated was 2015. And so for us, when we've done a couple of different PCL studies, we've gone to the most, like the most popular or most popular, I don't know if most popular is the right word, but the largest advocacy groups for any particular population. And within those advocacy groups, they usually have a language guide, or what constitutes stigmatizing language. And one of those studies we just published on was autism. And there's, depending on what group within the autism's realm or community you're talking to, have different perspectives on whether they want, whether you should use identity first or person first style of language. And among individuals who have autism, that are usually generally high functioning or have very limited symptomology, that they actually overwhelmingly referred to as autistic individuals. It's an innate trait to their being. It's not something that's curable. You can manage the symptoms that may be there. But overwhelmingly, that particular group within the community prefers identity first style. Whereas if you are looking at caregivers of individuals who have autism with severe limitations, functional or developmental, they are very much person first. They want their child or the person they're taking care of to be referred to as an individual. So we published this, just recently published a paper looking at person-centered language and autism, and we didn't characterize either person first or identity first language as stigmatizing. We just looked at the context of the paper, whether they used person first or identity first style of person-centered language, and whether it included other stigmatizing terminology like mentally ill, mad, schizophrenic, some other PDD, and mental retardation, things that have been eliminated from textbooks for years. And we found that when within the autism literature, we found that when identity first style was used, it more often was accompanied by those other stigmatizing terms. So within our paper, we agreed with the AMA style to use person first style because person first style usually comes with intentionality. It's not one of those things like writing addict is way easier and probably less conscious than writing a person with alcohol use disorder. So we suggested within that manuscript to write person who is autistic. And I know that's semantics and people are like, oh, it's just semantics, but like that refers to autism as an adjective in that context, which is a descriptive of their innate being rather than a person who has autism as a treatable condition. That might be like way out in left field, but just to give you an idea of how we've gone about some of our person-centered language studies.
Thank you. Let's see if we have any final questions. We're wrapping up a bit here. I don't see any other questions in the chat, I think. If anyone else has any questions, this would be a great time. Okay, we're gonna wrap up. Thank you so much, Dr. Hartwell, for your time. And Brett, Mr. Traxler, thank you for your time also. Soon to be doctor, I take it from your bio. Thank you. This was very interesting. We really appreciate you joining us and letting us learn from this. Thank you, everyone. And we will see you next month, Pain Research Working Group. Have a good rest of your day. Thanks.
Thank you.
Thank you.